Good evening. Assalamu alaikum. Can you hear me?
Alaikum assalam. Yes, doctor.
So we will start in a minute. This lecture is about hematological considerations in the care of dental patients, especially as regards to general approach to anemia, bleeding disorders, and blood transfusion. So I will be giving you an overview of the hematological considerations. It will not be the details of these disorders as we usually give in medicine, but it will be an overview so that the students of dentistry are able to approach such patients who have these common problems, especially anemia and the transfusion of blood and blood-related products. Okay? So I will start now.
Okay, doctor.
Okay. So first, I'll be talking about an important bleeding disorder known as hemophilia. It is an inherited bleeding disorder. It is an X-linked disorder. That means the disorder is affecting the males and the females are carriers. It is due to the deficiency of blood clotting factor 8, which is called as hemophilia A. Similarly, if this there is deficiency of clotting factor 9, we call it hemophilia B. And if there is deficiency of clotting factor 11, that is called hemophilia C. But hemophilia C is autosomal recessive in inheritance, whereas hemophilia A and hemophilia B are X-linked recessive in inheritance. So in all the cases of hemophilia, if the patient is bleeding, you have to classify what is the severity of hemophilia, and that depends upon the factor levels. So if the normal factor is 100% in a normal person, and in hemophiliacs, it can be in the range of severe, moderate, mild, and very mild disease. So if a patient has severe hemophilia, then if you will do their factor levels, in this case, the most common type of hemophilia is hemophilia A, due to deficiency of factor 8, their factor 8 level will be less than 1%, and sometimes it is undetectable 0. These patients have spontaneous bleeding episodes, and they start typically from the period of childhood, with the patient having recurrent episodes of bleeding into their muscles or joints. Bleeding into the joints is called hemarthrosis. They can have history of easy bruising and also prolonged bleeding, either spontaneously or from minor injuries or surgical procedures like dental extraction. So you have to be very careful when these patients come to you for any dental procedure, including extraction of the teeth. Initially, they may have normal hemostasis, but after some time they can have delayed but prolonged and severe bleeding, especially very important to note in severe hemophilia. On the other hand, in moderate hemophilia, the factor level is in the range of 1 to 5% of the normal. Normal is 100%, and they bleed with comparatively minor trauma, and which can lead to significant blood loss. On the other hand, in patients who are mild hemophiliacs, if you will check their factor level, in this case factor 8 level, it will be in the range of 5 to 25% of normal. They will have minor trauma leading to bleeding, sometimes significant bleeding, and including bleeding after dental extractions. And sometimes it can be the first or the only sign of mild hemophiliac disease. Patients who have very mild hemophilia, they have more than 25% factor 8 levels. These patients with very mild disease can essentially lead a normal life and can remain undiagnosed for a pretty long time. But in their case, there can be sometimes prolonged bleeding after trauma or surgery. Some of them may bleed, some of them may not bleed excessively after a simple procedure like a dental extraction. So you have to keep in mind that the absence of post-extraction hemorrhage cannot reliably be used to exclude hemophilia in these patients. Most of them will, however, bleed excessively after different types of traumatic surgeries, for example, tonsillectomy. So outline of management of hemophiliacs who are requiring surgery. For example, the operation can be a dental extraction procedure or a dentoalveolar surgery or periodontal surgery. And in these kind of surgeries, the surgeon has to ensure that the patient has at least minimum of 50% of the factor 8 levels pre-operatively, just before you start the operation. And for that purpose, you may give them prophylactic infusion of factor VIII intravenously, or a hemostatic agent, which is a drug which prevents bleeding or stops bleeding, and a very common drug in that class of drugs is known as tranexamic acid. You can give it 1 gram intravenously or orally starting at least 24 hours pre-procedure. And in the post-operative schedule, you have to maintain local hemostatic measures. You have to ensure proper compression of that area so that bleeding doesn't take place. In a major surgery, like a maxillofacial surgical procedure, you have to ensure that the factor VIII is between 75 to 100% at operation just before the operation starts. Most of the surgeons would like to keep it at 100%, and it should be maintained post-operatively for at least a week, not less than 50%. And again, for this purpose, you will give them infusions of factor VIII, intravenous infusions. How will you calculate the dose of factor VIII in units? It is given at the bottom. That is obtained by the weight of the patient in kilograms multiplied by 25. And this dose should be given 1 hour preoperatively. And factor VIII dose in units can be also calculated in maxillofacial surgery by multiplying their weight in kgs with the factor with value of 50, which should be given 1 hour preoperatively. And in maxillofacial surgery, post-operatively, you have to ensure all local hemostatic measures are in place. The patient should be admitted for at least 7 days with rest, unless there is some compelling evidence to discharge the patient before that, but not before 3 days. They should take a soft diet for at least 10 days. Also give them tranexamic acid, and for infection prevention, prophylaxis of oral penicillin V, 250 milligram Q6 hourly. Still, if there is bleeding during this period, you may give a super added dose of factor VIII with inpatient admission for 10 days and soft diet, and twice daily factor VIII infusions. So this is regarding the management of bleeding in patients such as hemophiliacs come to the dental surgeon or a maxillofacial surgeon for different kind of procedures. Now, this drug is a vitamin K antagonist. It is known as warfarin. It is used for a lot of indications. It's a blood thinner. It is commonly used anticoagulant, and don't be surprised that many patients will come to you for different kind of procedures who are already taking this drug because of different indications like deep venous thrombosis or pulmonary embolism or atrial fibrillation or thrombosis involving the vessels, including the arteries also. So a post-operative bleeding risk for dental procedures on the patients who are taking warfarin has to be considered seriously. And the dental procedures, you should note which are likely to cause bleeding and which are not likely to cause bleeding as much. And they have to be divided into low risk and high risk dental procedures. Low risk procedures are procedures like simple dental extractions of up to 1 to 3 teeth, incision and drainage of intraoral swellings. If you have to do a detailed 6-point full periodontal examination, if you have to do some root canal procedures like root surface instrumentation and subgingival scaling, direct or indirect restorations with subgingival margin. So these have low risk of bleeding in the post-operative period. But the procedures that have high risk of post-operative bleeding are complex extractions, which means the adjacent extractions that will cause a large wound or more than 3 extractions done at once together, or flap raising procedures such as elective surgical extractions, periodontal surgeries, pre-prosthetic surgeries, periradicular surgeries, crown lengthening procedures, and dental implant surgeries, gingival recontouring, and different types of oral biopsies. So what is the protocol for warfarinized patients having oral surgery? Warfarinized patients means who have been on warfarin for at least 5 to 7 days and whose international normalized ratio, which is the ratio of the prothrombin time of the patient divided by normal prothrombin time. How will you approach them? Pre-operatively, first you will check their INR. INR stands for international normalized ratio within 24 hours of the procedure. If the value of the INR is less than 3.5 and sometimes less than 3, and the patient has not any underlying liver disease, then you may not change the dose of warfarin. But if the patient has INR less than 3.5 and has a liver disease, or if the INR is more than 4, don't do anything unless you consult a hematologist or a physician about stopping or reducing the dosage of warfarin, and make sure the patient is not on any other drugs like antiplatelet agents like aspirin or other non-steroidal anti-inflammatory drugs. Perioperatively, minimize the trauma as much as possible. Use a regional block local anesthetic only if it is essential, and ensure local hemostatic procedures with no NSAIDs. Post-operatively, for at least 24 hours, give them rest. Tell them that they should be not doing any mouth rinsing. Do not take any hot food or hot drink. No chewing, no hard food, and no non-steroidal anti-inflammatory drugs. These are very important things that you have to keep in mind when you are dealing with these kind of patients who are on this drug, which is a commonly used anticoagulant. So this table is just telling you about the effect of warfarin and its interactions with other drugs and dietary products, because this drug has been seen that it has interaction with a lot of other drugs, and if the patient is taking warfarin along with any of the other drugs which are mentioned in the table on the right hand side, it may prolong the effect of warfarin and may cause significant bleeding. And you have to keep a close watch on these patients and monitor them with their coagulation profile, including INR. You don't need to remember these drugs, but just keep in mind that warfarin is a drug that has a big list of drug and drug-food interactions. And the classes of drugs that you have to be really careful about are the antibiotics like antibacterials, antifungals, antivirals, and psychiatric drugs like antidepressants and antipsychotics, and even analgesics such as non-steroidal anti-inflammatory drugs and aspirin. And the duration of action of the drug has to be also kept in mind. Now, I'm sure all of you can recognize what is this image. Can you tell me what do you see? What do you see in this image? This is a patient with gingival hyperplasia. This patient can come to a physician. This patient can even come to a dentist for oral or maxillofacial procedures, and it could be due to a number of reasons. It could be drug-induced, could be due to diseases like hematological disorders, like phenytoin is a drug which is used for the treatment of epilepsy, and it can cause gingival hyperplasia. A patient with leukemia, such as acute myeloid leukemia, can also have gingival hyperplasia with bleeding gums as well. So this has to be kept in mind when you see these kind of patients, and you have to find out what is the underlying cause of this gum hyperplasia, and it can be gum hyperplasia with bleeding. So gum hypertrophy causes, as I told you earlier, severe gum hypertrophy at the time of initial clinical presentation in acute myeloid leukemia, subtype M5. This is called as monoblastic or monocytic acute myeloid leukemia. And on you can see another patient on the right side who has significant gum hypertrophy, and these gums can bleed easily, and they can have oral. So remember these causes of gum hypertrophy, which I told you earlier: drug-induced, especially phenytoin, which is an anti-epileptic drug, and there is a drug which is used in cardiovascular diseases such as hypertension, which is nifedipine, and in medical disorders such as acute myeloid leukemia. Now we'll be talking about anemia. Just a basic definition of anemia. Anemia means decreased oxygen carrying capacity of blood. The definition of anemia is variable. It depends upon the gender of the patient, whether male or female. It also depends upon whether the patient is at sea level or at high altitude, and also dependent upon the different underlying etiologies of anemia. But in general, the definition of anemia for an adult male is when the hemoglobin is less than 13 grams per deciliter or 100 ml of blood. For an adult female, if it is less than 12 grams per deciliter of blood. And in case of a pregnant female, anemia is considered to be present when the hemoglobin is less than 11 grams per deciliter. Now, what are the causes of anemia? Causes of anemia are, it's a big topic. It can be divided according to the type of anemia, like we have normocytic, normochromic anemia, microcytic hypochromic anemia, and macrocytic anemia. Or the other classification, which means megaloblastic anemia, or it could be nutritional anemia, which includes iron deficiency anemia. And it can be because of different types of hyperproliferative anemias and hemolytic anemias, or due to bone marrow failures. And then how will you approach such patients? Any kind of specialty can receive these patients who have anemia of different types. And how will you treat them? You have to know the basics of that. So look at this CBC on the right-hand side. It shows the white blood cell count of 5.5. That means 5,500. And below that is the differential: neutrophils 54.7%, lymphocytes 34.1%, monocytes 7.5%, eosinophils 3%, and basophils 0.7%. The red blood cell count 4.28 million reduced, it's low. The hemoglobin of this patient is 9.7 grams per deciliter. The packed cell volume or hematocrit is 29.9. Now look at the further values. MCV, it stands for mean corpuscular volume. MCH, mean corpuscular hemoglobin, and MCHC, mean corpuscular hemoglobin concentration, and RDW, which means red cell distribution width. And below is the platelet 331, and MPV stands for mean platelet volume of 8.8. Now, when you have to approach a patient who has low hemoglobin or anemia, the next thing that you will check in the CBC is at the value of MCV and MCH, and probably also MCHC. MCV means what is the size of the red blood cell. The normal size of the red blood cell or mean corpuscular volume is between 78 to 98, or some books mention between 80 to 100. If it is less than 80 or less than 78, we call it microcytic anemia. However, if it is the patient has hemoglobin of less than the definition lower limit of normal, say for example 12 or 13 in male and female respectively, and the MCH is greater than, MCV is greater than 100, then we call it macrocytic anemia, like megaloblastic anemia due to vitamin B12 deficiency or folic acid deficiency. However, if the MCV is in the normal range between 80 to 100, but still the hemoglobin is less than the lower limit of the normal range, then it is called normocytic normochromic anemia. So whenever you see the CBC and the hemoglobin is low, the next thing that you have to look is at the values of MCV and MCH, and probably also MCHC. L means low, H means high. So this patient has a hemoglobin of 9.7, which is obviously low. So he is or she is anemic. Then look at MCV and MCH, they are both low. So this is microcytic hypochromic anemia. The causes of microcytic hypochromic anemia are important, and they are not many, but you should know them. The most important is iron deficiency anemia. Second is thalassemia, especially beta thalassemia. And third is lead poisoning, and fourth is sideroblastic anemia. But out of these, the most common cause of microcytic hypochromic anemia with these values is iron deficiency anemia. So the next step here is you will check the patient's serum iron study. That includes serum ferritin and transferrin saturation and serum iron. And if that is low, you will confirm that this patient has got iron deficiency anemia, microcytic hypochromic. On the other hand, if the patient has normal ferritin and you do a hemoglobin electrophoresis, and that tells you that the patient has abnormal beta globin chain of the hemoglobin, then it is secondary to beta thalassemia minor or beta thalassemia trait. On the other hand, if the patient, you will do the serum lead levels and the lead levels are present in toxic range, then this microcytic anemia is secondary to lead poisoning. Or if the patient, you will do their peripheral blood smear, and you will check that there are presence of granules around in the red blood cells, which are known as sideroblastic granules, then this is due to sideroblastic anemia. So this is how you approach these patients with microcytic hypochromic anemia. So this is a 25-year-old young girl who presented to your clinic for regular dental checkup. On clinical examination, you notice that she has pallor, she looks pale, and then you ordered CBC and you saw these values. And the interpretation I have already told you. So this is the first case study. Now look at the second case study. So is the hemoglobin normal or low? This patient has normal hemoglobin or reduced hemoglobin?
Reduced, doctor.
Okay, good. Now look at the MCV. Is it normal, low or high? MCV.
High, doctor.
Good. And the MCH is also high. You can see
Yes.
the value H. So what kind of anemia is this? Is it microcytic, normocytic, or macrocytic anemia?
Macrocytic, doctor.
Very good. So this is macrocytic anemia. And then you should know what are the causes of macrocytic anemia. It can be due to vitamin B12 deficiency, or it can be due to folic acid deficiency. Or sometimes in patients who have acute blood loss, they can also have macrocytic picture. So this is a patient with macrocytic anemia, and the most important cause of which is megaloblastic causes or megaloblastic anemia. And here you have to check their serum vitamin B12 levels or red blood cell folate levels. So again, so in this case study, a girl comes to your clinic for evaluation, dental checkup. You again notice that she looks pale. The first thing that you will order is a CBC, and the CBC will help you like this. So I'm telling you clinical aspects. These kind of patients you'll be seeing in your practice, and this is how you have to approach them. Then later on, for further evaluation of anemia, you can refer the patient to a physician. Now, clinical presentation of anemia. These are the common signs and symptoms of anemia. As I told you earlier, anemia means a reduced oxygen carrying capacity of blood. So these patients have low hemoglobin and low hematocrit. And to some extent, if their underlying cardiovascular system or the cardiopulmonary system is normal, they may withstand the effects of low hemoglobin to some extent. But if the hemoglobin keeps on falling more and more, there will come a time then the patient will become symptomatic, and that is called symptomatic anemia. And these are the common symptoms and signs that the patient with anemia may develop. So they can have generalized fatigue, easy fatigability. They can have weakness, effort intolerance, dyspnea or breathlessness on exertion. They can have palpitations. They can, in severe anemia, the palpitations can be quite prominent, and they can have worsening breathlessness. And sometimes in severe anemia, they may develop a ringing sensation in their ears, which is called tinnitus. They may have blackouts, pre-syncope, or even syncope. They can have severe headaches at times when the hemoglobin is quite low, usually when it is less than 5 or 4. And if the patient has underlying cardiac disease, they can develop congestive heart failure or chest pain, angina pectoris. They can have memory impairment or cognitive decline. They can have dizziness, drowsiness, and they can have apathy. On physical examination, when you will check their eyes, their skin, they will have pallor. They can have increased heart rate, tachycardia. If you will check their pulse, it will be high volume pulse, which is called a bounding pulse. Sometimes because of severe symptomatic anemia, if you will auscultate their heart, you will hear a functional systolic murmur, which is called a hemic murmur. And in severe cases, they can go into high output cardiac failure. So don't be surprised that patients of severe anemia can come to you in heart failure. Look at the two hands, and you can see this smaller hand on the right hand side is pale. So a brief overview of the etiology of anemia. If there is decreased production of the red blood cells. Now, you should remember that all the cells, blood cells, red blood cells, white blood cells, and platelets, they are synthesized, they are produced in the bone marrow, the red bone marrow, inside the bones. So what anemia can happen because of hypoproliferation, which is called as hypoproliferative anemia, due to decreased production of the red blood cells. And the red blood cells need iron, they need vitamin B12, and they need folic acid for normal production. So if these are deficient, then you will have anemia. So it could be secondary to iron deficiency, vitamin B12 deficiency, or folate or folic acid deficiency. On the other hand, if the production of the red blood cells is normal, but they have an accelerated destruction of the red blood cells as in the vascular system or in the extravascular portion, like such as spleen, that is known as hemolysis or hemolytic anemia, which is of two types: intravascular hemolysis and extravascular hemolysis. It can be seen in sickle cell anemia, which is common in this part of Saudi Arabia, and so also is thalassemia. And we have other type of autoimmune disorder, which is known as autoimmune hemolytic anemia, which is of different types and which can lead to serious episodes of hemolytic anemia. Acute blood loss due to any bleeding episode can also eventually lead to anemia. Now, iron deficiency anemia. This is by far the most common cause of anemia globally, all over the world, and especially common in females of the reproductive age group. So what are the causes of iron deficiency anemia? In the diet, if you have insufficient intake of iron, if you have malabsorption problems, you have malabsorption syndrome where there is impaired absorption of iron from the intestines. The major site of absorption of iron is in the small intestines, especially the duodenum. Or if you have blood loss due to different type of conditions where there is bleeding, or sometimes when there is increased requirement of iron as in pregnancy and lactation, or you have a trauma and there is sudden acute blood loss, you can also have loss of iron and iron deficiency anemia, or you have sometimes intake in your diet of some chemicals such as polyphenols, which interfere with the absorption of iron and do not allow iron absorption to take place. So these are the main causes of iron deficiency, which eventually can lead to decreased body iron stores, which eventually results in iron deficiency anemia. Actually, iron deficiency anemia has stages. The first stage is patient is clinically asymptomatic, but there is progressive depletion of the body iron stores, which is mainly stored in the liver and the reticuloendothelial system. And then once the iron gets depleted, then the hemoglobin starts following, and that is the last stage, which we call as iron deficiency anemia. Before that, we have latent iron deficiency without anemia. How do we diagnose anemia? It is fairly simple. Based on the history and the clinical examination, you will look for the signs and symptoms. As I told you earlier, this slide, this is history, symptoms, and physical examination signs. But this is not enough. You have to confirm what is the exact type of anemia, and then you will do lab tests. The first lab test that you will do is CBC, or complete blood count. CBC will tell you that there is anemia and whether it is microcytic, normocytic, or macrocytic. And then you will do another blood test, which is called peripheral blood smear or peripheral blood film. That will tell you about the morphology of the red blood cells. And then you will do some additional tests to find out the underlying cause, including complete metabolic profile. You will do hemoglobin electrophoresis. And depending upon the type of anemia, you may check for serum ferritin, serum iron levels, or vitamin B12 levels, or folic acid levels, or other causes of anemia according to the different individual presentation of the patients. So first test that you have to always do is complete blood count, CBC. So this is a normal CBC. You can see the values, the components and the values, the ranges given on the right-hand side. And the CBC is done from an automated machine, like you see here on the right-hand side. You put the blood sample here, and it will give you computerized automated values, and so it is very easy to obtain it. But it gives you a lot of information, not just about the red blood cells, the hemoglobin, the white blood cells, the platelets, the MCV. Here, see the normal range of MCV is 78 to 98 femtoliters, MCH, MCHC, and the differential of neutrophils, band forms, lymphocytes, monocytes, and eosinophils and basophils. So morphologic classification, what does that mean? Morphologic classification means what is the type of anemia based on the size of the red blood cells. As I told you earlier, if the MCV is between 80 to 100, it is called normocytic anemia. If the MCV is less than 80, it is called microcytic anemia. And if the MCV is more than 100, it is called macrocytic anemia. So then according to microcytic, normocytic, and macrocytic, you can divide it into different types of anemia. Like important causes of microcytic anemia is iron deficiency anemia and thalassemia. Normocytic is hemolytic anemia and blood loss, and macrocytic anemia is B12 deficiency, folate deficiency, liver disease, and those who are alcoholics. So these are the main types of anemia: microcytic hyperchromic, macrocytic, and normocytic. Microcytic Hypochromic anemia is iron deficiency and thalassemia. Macrocytic is vitamin B12 deficiency, folate deficiency, hemolysis, hypothyroidism, liver disease, aplastic anemia, and normocytic anemia is due to chronic diseases, chronic kidney disease, renal failure, hemolysis, and again hypothyroidism. So these are the important causes that you have to remember. And remember that blood loss from menstruation or occult blood loss from gastrointestinal or genitourinary tract or malabsorption, including surgery such as post-gastrectomy, will lead to macrocytic anemia. Malabsorption, again after surgical removal of the stomach, can also give rise to macrocytic anemia. So post-gastrectomy, you can have both microcytic hypochromic anemia as well as macrocytic anemia. So this is CBC of another 25-year-old young female. She looks pale. You ordered CBC. Here you see that the hemoglobin, this is what we have already discussed earlier. This is microcytic hypochromic anemia because the MCV and MCH both are low. Okay, just wait. So diagnosis. How do you confirm the diagnosis of iron deficiency anemia? The most important diagnostic test is you request serum ferritin level. Serum ferritin level is the level that will tell you about the body stores of iron protein called as ferritin. It will be reduced. The answer is serum ferritin level, not serum iron. Remember that. Serum ferritin assesses the overall store of body iron stored in the body, including the blood and the tissues such as liver. But on the other hand, serum iron will assess only the amount of iron that is present in the serum, not in the body tissues. So the best answer is serum ferritin. Now, treatment of iron deficiency anemia is you have to give them iron. So iron deficiency anemia is not a diagnosis per se. You must always look for the underlying cause that resulted in iron deficiency. So this is in Arabic. I will skip this part because I will explain to you in English. Now, in iron deficiency anemia, there is deficiency of iron. Now, how do you prescribe iron? Iron should be taken between the meals. And you should make sure that inhibitors of iron absorption, which is calcium-containing foods such as milk products, dairy products, tea, coffee, should be avoided whenever you have to give iron supplements. You have to also take care of medications that reduce the gastric acidity, such as antacids, because iron needs acidity in the stomach for normal absorption. And if you use too much of antacids and proton pump inhibitors, it may impair the absorption of oral iron, and therefore it should be not given at the same time or avoided at that time. Sometimes you can give oral iron with vitamin C, such as in orange juice or ascorbic acid, which is the medical name of vitamin C, because vitamin C can enhance or increase the absorption of iron from the gastrointestinal tract. So this is, some patients cannot tolerate oral iron, or they have contraindication to oral iron because of side effects. Then you give them intravenous iron. This is ferric carboxymaltose iron. This is a very useful form of intravenous iron. You give it in 1 or 2 doses, 500 milligram or 1000 milligrams, and you just give it once, and you repeat the patient's serum ferritin after 1 month, and you will see that it has usually improved a lot, and the patient, you will check them again after 1 month, they will come to your clinic, and you will see that everything has come back to normal, and the serum. Okay. To the patient that we talked about with macrocytic anemia, you can see that the MCV is high. This we had discussed previously. And what is the cause of this? It is megaloblastic anemia, and it is either vitamin B12 deficiency or it is folic acid deficiency. And here, what the treatment is that you have to give them either vitamin B12 orally, or you have to give them intraparenterally, such as intramuscularly, or you have to give them if it is due to secondary to folic acid deficiency, then you have to give them folic acid supplementation, and this will improve the anemia. Now we come to the last part of blood transfusion. If this lecture finishes, then I will just extend it for another 10 minutes, and we will finish in another 10 minutes maybe. So now blood transfusion. So blood is given as a transfusion for patients who have significantly low hemoglobin and who are clinically symptomatic, and you have to give them packed RBCs. So what is blood transfusion? It is administration of blood, packed red blood cells, or other components through an intravenous route. So for blood donation, you have to first identify the donors, which should be healthy individuals who have no blood-borne disease. You may even ask them a questionnaire so that you will rule out diseases before selecting these patients for blood donation. Before you select them for blood donation, you have to check their hemoglobin level by doing CBC, and you have to do their blood grouping according to the ABO-RH grouping system. You have to rule out that they do not have any infections such as hepatitis B, hepatitis C, human immunodeficiency virus, HIV, or other transmissible infectious diseases. And then you have to separate the whole blood, and you may have to store it in a blood bank. The whole blood contains packed red blood cells, platelets, concentrate, plasma, and plasma products. And you can separate out one or more of these components, and you may give component transfusion of these blood cells as and when required. So what is the purpose of blood transfusion? Restore normal blood volume, replace the deficient blood clotting factors by giving cryoprecipitate, and if the patient is severely anemic, improve their oxygen carrying capacity. By that, you mean to improve their hemoglobin in the normal range. And if they have depletion of different elements, such as they have thrombocytopenia, you give them platelet transfusion, you can restore the blood elements that are depleted. And to prevent complications due to the lack of these important components of the blood. So we have whole blood. It contains cells and plasma. The cells are red blood cells, platelets, and white blood cells. You can give them separately as red blood cell concentrate transfusion, platelet transfusion, or transfusion of white blood cells if required in immunodeficient patients, or you can give them plasma. In plasma, you can give them fresh frozen plasma, which is rich in all the different types of clotting products, or you can give them cryoprecipitate, which is rich in factor VIII, or you can give them fresh frozen plasma for prevention of bleeding, such as in patients who have DIC. Sometimes you may give them albumin transfusion, immunoglobulin transfusion, or transfusion of individual coagulation factors or other plasma protein products. So this is the different types of transfusions that we can give from the blood and blood products. So indications of blood transfusion, most common indication is as symptomatic anemia. So whole blood has red blood cells, white blood cells, plasma, platelets, hematocrit, and clotting factors. You give it for volume replacement and increasing oxygen carrying capacity if the patient has significant blood loss and sometimes in hemolysis, including newborn babies with hemolytic anemia. Packed red blood cells contains RBCs. They increase the red blood cell mass and oxygen carrying capacity, and you give it for symptomatic anemia, acute anemia, as well as chronic anemia, and to avoid blood loss due to vascular injury or at the time of trauma or surgery due to blood loss. Platelets are given in patients who have thrombocytopenia or who have normal platelet count but abnormal platelet function, that is known as platelet dysfunction, such as patients who have end-stage renal disease, such as disseminated intravascular coagulation. Fresh frozen plasma